What up, everybody? This is the Modern Medicine Podcast. I am your host, Dr. Dennis Tian from the Boston Podcast Network. Recording tonight, we have a great episode planned for you today. I'm joined, as always, by the producer, Dave Yaz. Dave, how are you doing today, my friend?
Good. It's a Friday, and you seem to be coming in hot.
I'm coming in red hot today. It's the spring weather. It's an absolutely gorgeous day today.
It is, finally. And I noticed looking at the forecast that, it'll be okay this weekend, not great, and then Monday and Tuesday are beautiful. Of course, that's what we get.
That's what we get. Yeah. 13 straight weekends of rain.
Yeah.
It's unbelievable. We have a great episode today to lessen the blow of all these bad weekend weathers. Hopefully keep people interested as we go through all this spring rain. We have a terrific guest, Dr. Pratik Pradhan. He is an ENT doctor in Norwood, and he is going to talk to us a lot about some of the hot topics in ear, nose, and throat right now, and specifically, Dave, and I'm looking at you, sleep apnea.
Here we go.
And testing and alternatives to treatment, which I know is a hot topic for a lot of people. We got some great stuff in the news. We got a great clinical case of the month. And as always, we will wrap it up with the non-medicine topic of the week at the end, which I will keep a surprise until we get there.
Teaser. I like it.
Teaser.
Yeah.
Spoiler alert.
Yeah.
Okay, great. Well, let's get right to it. Let's start within the news.
In the news.
And I want to begin with a big story, and we've talked about this a few times, but I got to bring this up because this is really important to a lot of my patients, and I'm guessing to a lot of all the people out there. And that is the GLP-1 coverage by insurance companies. So last episode, I think we discussed that Blue Cross was going to stop covering Ozempic for non-diabetic patients January 1st. Since we last recorded, now Tufts and Harvard Pilgrim have also decided the same. So that means if you have Tufts, Blue Cross, or Harvard Pilgrim insurance, and you're using Ozempic and you're not diabetic, effective January 1st, you are losing coverage. This is going to be a huge problem in my office. We are going to have a lot of upset patients when this happens, and I think people need to be ready for this.
So what if you have a script for Ozempic now and this sea change occurs, are you just out of luck? Or,
yeah, I mean it sounds like it. Yeah. It's you pay on your own, which is going to cost hundreds to maybe even $1,000 a month, or look into changing insurance products. But when I say those three big payers are changing on January 1st, I actually heard from a patient that has a less popular insurance, a smaller plan. I don't even want to say which one. It was one of the smaller ones. They're actually cutting coverage on July 1st. So it's not just these three. It's actually a lot of them. So I don't know what people should do. I really don't. If you're using these meds for weight loss, I think the first step would be to call your insurance company.
This is potentially seismic. I know so many people that are on Ozempic, and I don't think they have a clue that it could all come to a crashing halt. So it's a shame.
That's exactly right. And people are going to be upset. And I legitimately worry for my office staff because we're the middle people. We're stuck in the middle of this, and there's not going to be any leeway. I think there's going to be no prior auth. I don't think there's going to be much in the way of appeal. There is a way that if the insurance subscriber, meaning say you have employer insurance, your employer, they might be able to select a product and pay more for it that still covers it. But that's going to be at the discretion of the subscriber. For most people, they will lose coverage.
Oh, boy. All right. Well, good luck, everybody.
Yeah, it's going to be a nightmare. Call your insurance, everyone, and be ready. Make a plan for that. Okay, next one I want to talk about is from an article I saw on NPR on May 21st. This is something we discussed, Dave, when Dr. Napoli was here. FDA cleared Alzheimer's blood tests could make diagnosis faster and more accurate. So the FDA has now approved a first of its kind to be cleared by them blood test to diagnose Alzheimer's disease in people over 55 that have memory problems or other signs and symptoms of dementia. So this is a big deal. And it brings to the forefront, I would say, a lot of ethical considerations. So what I want to ask you is, would you even want to know? Would you even want to do this test and know that you have Alzheimer's?
Is it so? It tests if you actually have the disease, not necessarily that you're just prone to the disease. Is that right?
I believe it's and I mean, this is a new test for all of us, but I believe it is it is not just testing if you're prone. It is testing if you have the disease with some degree of accuracy. In fact, I think in the studies that got the FDA approval, the accuracy was better than, say, like a clinical diagnosis.
Well, obviously Alzheimer's affects so many people, and it's in a really cruel way that the person just kind of slips away. I mean, I guess I would want to know. I mean, that's another one of the cruel aspects of Alzheimer's is that a lot of times the person seems oblivious to the fact that they can't remember who their cousin is that they've known for all their life, and they're looking at it, sorry, we haven't met, and no, Bob, this is your cousin Larry, and so you'd want to know, right?
I think you would, and I'm just gonna point back to our interview with Dr. Napoli, which is that we're developing treatments for Alzheimer's too. And I think Alzheimer's is becoming a more treatable disease. Some of the newer infusion drugs that can actually change the natural history of the disease. And I think that's what sort of opens the door for these tests being worthwhile. I mean, if there wasn't anything you could do about it, I'm not sure I would want to know, to be honest with you. Let's remember one thing. We're talking about people that are in the early stages, right? We're not talking about people that don't know what they're doing. We're talking about people that are like just starting to forget things, but are still really functional and relatively young at 55 plus. That's a younger person. So
thank you.
Absolutely.
That's
it's
me.
the truth. So there's a lot to consider when you make that decision. But I think the way the treatments are now, I feel like, this is something people want to think about if they're showing these signs and symptoms.
Is early detection important in Alzheimer's?
Absolutely, especially now where these new treatments seem to work better the earlier they're started.
So the way this is going to emerge is when all of a sudden, like for a week in a row, you can't remember where you put your car keys, and you're like, maybe I'm slipping a little bit. So you're still mostly with it,
right?
And yeah, I mean, I would want to know. I wouldn't want to get the bad news,
right.
but and that's, correct me if I'm wrong, but Alzheimer's doesn't happen in a snap overnight.
No.
It's a slow...
It happens over decades.
Yeah.
It happens over decades,
Yeah.
years and decades. And just to bring it back to the first point, the article is over 90, the test is over 90% accurate. So this is a very accurate test. It's more accurate than primary care doctors. It was more accurate than even neurologists at diagnosing early dementia. So, this is a game changer, and it's gonna change the way we practice. People are gonna want this test, and it will, I think, funnel a lot of people into some of these newer treatments.
Well, we had bad news on Ozempic. It's mostly good news on Alzheimer's. We'll take it.
I think so. I mean, hey, for the first time, we're living in an era where you can actually do something about Alzheimer's dementia, potentially treat it, delay it, slow the natural history down with these new drugs, and who knows where that's going to be in 5 or 10 years. It's probably only going to get better. So I think that's a great thing. Let's talk next about the MAHA report. Did you see the MAHA report, Make America Healthy Again, released this week by RFK?
I did not.
Okay. So
let's talk about it.
70-page report based on an executive order by the president, Donald Trump. I know everybody or a lot of people around here want to hate on RFK Jr., and I completely get it because a lot of the things he said and done are borderline quackery. But I also have to say not everything that he's doing is wrong or bad. And I did kind of like some elements of this report. Now, what I didn't like about this report was that it cited 7 studies apparently that don't exist, which is just embarrassing and unacceptable. But what I did like about it is its focus on lifestyle and health in children.
I'm glad you're doing this because I do think RFK Jr. is a little bit crazy. The evidence is there, but in the reporting of this story that I admit I'm just sort of taking a look at now, but much of the reporting, the angle is what you just said, is that there are studies that don't exist. It looks like this whole thing could have been written by ChatGPT, but just because he's we don't love the fact that he's in this position doesn't mean he doesn't have some good ideas. So I mean, let's be balanced about it. I can't remember off the top of my head, but there are some things he says that make sense.
There are, and just to look at the report and what it focuses on and why we have so much, why our children have become so unhealthy, poor diet, is number one, which is 100% accurate. We have a terrible diet and so many processed foods. One of the other topics we might talk about is some of the dangers in processed foods next. So suffice it to say, that's not a good thing. And we know that, when people pick up metabolic risk factors in childhood, they will develop heart disease. Like it doesn't matter what age you are. If you have high cholesterol, whether you're 70 or whether you're 7, you're going to begin the process of atherosclerosis. And so with eating all these ultra processed foods, and 2 decades later, you'll have heart disease. You know what I mean? So eating all these ultra processed foods is clearly leading to some of these things like diabetes, like high blood pressure, like high cholesterol in children. And then these children are beginning the process of cardiovascular aging 30 or 40 years earlier, or 50 years earlier than they should. And it's affecting their health, their longevity in young adulthood.
Yeah, it's one of these examples of how, as we march on in society, they come up with new ways, new scientific ways of treating illnesses and things that are undoubtedly a good thing. But they also are coming up with new ways of preserving food and packing food and creating new, synthetic things to put in your mouth. And it's troubling that, I don't know if you would lump this in as well, but the proliferation of food allergies over the past decade or so. When I was growing up, there might have been 1 in 1,000 kids that had a peanut allergy, and not to get too conspiratorial, but there are theories that the spike in cases of autism are maybe something in the environment, including the chemicals in foods, and so. But we're supposed to be a great nation. We're not supposed to be the fattest nation in the world, but that's the way it's turning out.
And it's been that way for a long time. And I think, in my generation and your generation, I think it was bad. And I think it's getting worse now. And I think back to like when I was a kid, and I remember drinking this stuff called Jolt Cola. Do you remember this stuff?
Yeah, twice the caffeine.
Twice the caffeine, like twice the sugar. Like that was bad. And, you'd go to the convenience store. There'd be so many like processed foods and Twinkies and like chips and all this stuff. I think all of that, like pound for pound, is even more processed and worse now than it was back then. I really feel like the kids today, I just feel like it is all so toxic, the food.
Yeah, with all the information we have about nutrition, and years ago we didn't realize how carbohydrates could make you overweight. We thought eat as much pasta as you want, it's fine.
Right.
And yet, Mountain Dew doesn't seem to be going out of business.
No. Nope.
Kids are still chugging that stuff.
Well, that's just it. Like we talk about Jolt Cola, right? Like now you could go to Starbucks or Dunkin' Donuts, and there's going to be 20 products that probably have even twice as much caffeine as that did. So
there are entire refrigerators, those sort of half fridges in the supermarket filled with those energy drinks.
Right.
Just you might as well take a bowl of sugar and pour it into your mouth, right?
And it's poison. It's just pure poison. And that's what these kids right now are being raised on. And I really think it affects their metabolism and their metabolic health early on. And I think it affects them for life. And I think the damage that's done early on, I think studies are telling us that it's hard to overcome that, or it's harder to overcome that later in life. So it really does count. Aggregation of environmental chemicals was another report, another topic area the report focused on. That's a big thing. I mean, there's just so much stuff in everything, in clothes and furniture and food and food containers. Again, it feels like it's getting worse and worse. So I think that's a big thing. Lack of physical activity and chronic stress. Now, lack of physical activity is a huge problem in all Americans, and certainly young people. Screen time is a big thing. Screen time is a big problem. Kids play with more computers now. Like I grew up in the Nintendo era and the N64 and Super Nintendo, so we did that stuff, but it wasn't like our life or our focal point. It was just like one thing we did at times. We also did a ton of physical activity. I don't see kids playing independently anymore.
Well, you just said it. They're not playing. They're more likely to be on the way to their AAU basketball game. Right. They're playing more sports, more team sports, but those are all scheduled. And like in our day, you played on the little league team, but then there was all this time to fill. So you went outside, you played wiffle ball, you shot hoops, you rode your bikes. Right. And I feel like maybe these kids, by the time they get home from all these scheduled sports activities, they're exhausted and they just play video games.
I mean, like I grew up at a time where every day you from the time you got out of school until dusk, you just went out.
Yeah.
At 10 months a year, all in the summer it was all day. And you played sports, whatever it was, with whoever was around. And that's just what you did. Right. And, we did all the organized sports too, the baseball and football and different things. But when we didn't do that stuff, it was just like we were out. We were on our bikes walking. And I feel like I just don't see that as much anymore.
It's certainly not as much.
The culture has really changed. So that's a big thing. And then the last one the report identified was over-medicalization, which is another one that I think is actually a great point, a trend of over-prescribing medications to children. I've been saying this since I was in medical school. This is a big thing. I used to work as a social worker. I used to work at the Italian Home for Children. We get these kids on a lot of medicines at young ages and psychiatric medicines, and we overprescribe medicines to kids. I'm sorry. We are too aggressive. We have lost sight of the forest for the trees, if you will. And sometimes solving one problem in the short term and creating 10 in the long term is not a good deal. Even if there's a study that says, yes, in the short term, this makes sense.
What are the chief culprits? I'm going to go ahead and guess there are some ADD and ADHD drugs that are
I think that's the top of the list.
It is. Okay.
I absolutely do. I think these meds are frankly tremendously overprescribed. And I'm an adult doctor, so I see these kids now when they come into me when they're in their like 40s and 30s and they're still on them. Yeah. And where's the end point? Where's the end point? And a lot of some of them need them, but a lot of them I think could get by without them and just don't know how to. And that's really sad because they were put on them at such a young age.
Yeah, I remember years past, and this will happen from time to time, there's a shortage of Adderall, the ADHD drug. I remember a physician being quoted in the news. They said, well, are people going to suffer, health, hazards because they're not on Adderall? And the doctor said, to tell you the truth, for the most part, they'll just all be a little bit spacey for a few days.
Right.
And you don't want to put your kid on a permanent medication just because they're a little spacey.
That's what kids are supposed to be. And we're trying to fit all these kids into square pegs into round holes, a lot of them. And I think we're creating long-term problems for them. Instead of letting that process, that painful process of growing up that isn't always easy, we're not letting it happen. We're giving them these medications and we're setting them up in adulthood, I think, for bigger problems. I really see it in my office pretty much all the time. And I prescribe these meds for a lot of people, don't get me wrong. But every person that I prescribe these meds to, we have that conversation about risk, benefits, what's the end point. There's literature that these stimulant medications are bad for your heart. And that's been hard to prove for obvious reasons because it takes decades to do a study like that. And when you start something in childhood, certainly. But there is some preliminary data to suggest there is potential implications to your cardiovascular health and serious ones. So, we just talked about a study last week about antidepressants, which a lot of kids get, and sudden cardiac death and what those are doing to people. So I think you really have to be careful. These meds are good things when they're used right, but they are not a panacea, and they are not for every little problem, every little bump, every crisis of life and childhood is not going to be solved by a pill. And unfortunately, I think that's the way we've medicalized everything. We've made it that way, and it's not a good thing. So just to tie it in a little, Dave, to the Maha report and a couple other in the news topics that I saw this week that I thought really tied in nicely to some of the things we just talked about in the Maha report that was released this week. And one is this was from the research presented at the American College of Cardiology Asia 2025 conference. Consumption of ultra-processed foods may be associated with adverse health outcomes, including hypertension, cardiovascular disease, cancer, digestive diseases, and overall mortality. And that with every 100 grams increase of ultra-processed foods every day, the risk of many of those bad outcomes went up. So processed foods, not good.
We knew this, but we might not have known it to that degree. It's just odd to think that, again, with all the advances in technology and things we can do with foods, that it, in some ways, it's worse than it was in like 1955. When, 1955, you went into a diner and the food you were getting was going to be fresh, right? It wasn't packed away somewhere because they didn't have the techniques to do so.
And now they do.
Right.
But I think too, like we've built a food system that is literally built on refined carbohydrate. And then we wonder why we have like ridiculous rates of diabetes, pre-diabetes, and ultimately cardiovascular disease. Literally, most Americans are getting like 50 to 60% of their calories from refined grain. Refined grain spikes your blood sugar. That causes inflammation. That causes atherosclerosis, and that leads to a lot of the bad stuff that we're talking about. It's oncogenic. It's insulin and insulin spikes are anabolic, so they promote cell growth, which is we think is why so much of this ties into cancer risk, because obviously cancer is a disease of dysregulated cell growth. And I think that just overall we don't have the whole picture yet, but clearly avoiding processed foods. Very limited. If you could cut, say, from 50 to 60, like most Americans, percent of your calories, if you could cut that to like 10, you'd be doing real well. You don't have to eliminate it. You don't have to be zero. You don't have to be militant. You don't have to join a monastery. Just cut it back a little.
Mediterranean diet, right?
That's exactly right.
Come
That's
on.
a Mediterranean diet. And then one other quick one, Neuroscience News article about more social media leads to more depression, links cause and effect. So this was a study of kids. Long story short, without getting too much into the weeds on this one, because it was a pretty complex paper, the take home was the more social media kids used, the more likely they were to be depressed.
Yeah, that comes from the Institute of Things We Really Should Have Known in the first place. Like, I mean,
that study was announced by Captain Obvious.
But it's good we're talking about it, because there doesn't seem to be any end in sight, right? Kids are on their devices. And, there was a good documentary on Netflix, probably about 5 years ago, just about really breaking down how, why the kids are always clicking on a TikTok video, why they're always looking for how many likes they can get on their recent posts, because they get a little dose of, what's the chemical that makes you feel dopamine? Yeah. And so they sort of get addicted to that, but it's this empty pursuit, and it's, oh man, is it sad?
It is. And I just look at my own kids. As you know, I'm a father of four, and like just how important and pervasive screens are into their life, and how much that's changed. And it's just, it's stunning. But I think, like, who knows, I this is a little bit of a crazy thought and maybe a little radical, but I do think sometimes, there was an entire generation of people that smoked tobacco and didn't have there were generations of people that smoked tobacco and had no idea that there were health consequences. It took probably hundreds of years before people figured out that this was really bad for you. And I look at all this social media stuff and I'm like, what are they going to be saying? How does this affect our brains? Like 50 or 100 years from now, are the rates of dementia going to skyrocket in my generation and in my kids' generations, so that 100 years from now, we're looking at all this screen time and saying this is actually brain toxic somehow? Yeah.
And, there's no end to the harm it can do, not only causing depression, but causing, we have cyber stalkers, we have cyber bullying, we have the incredible sad story of a Massachusetts young man who committed suicide because his girlfriend kept sending him these texts encouraging him to do so. And, it can be used for good, but unfortunately we're a nation that is, maybe more divided than ever. And maybe it's because we're communicating with these robotic devices rather than face to face.
Yeah, and you wonder how, like, the whole AI revolution is going to factor into this too, where everything is already so screen driven and information computer driven, and now we're adding in this huge game changing technology that is literally going to change the way we work, the way what we do, how we spend our time. Like, how is that going to factor into all this and really human health? It's really interesting to think about.
Yeah, I mean, I'm reminded of the Joaquin Phoenix movie, which was called Her, which takes place in the not too distant future, where he has an AI bot that he talks to and falls in love with the robot and starts, quote unquote, dating the robot. And it was seen as this sort of dystopian view of the future, but It's pretty close right now.
Yeah,
right?
yeah.
We're getting there.
It's not that far away.
Right.
It really isn't. It'll be interesting to see. I've said, and my policy on this is very clear, that I'm way more scared of real humans than AI. I mean, if you look at our track record, let's see AI even do 1/10 the harm that we've done before I start to
That's
really
a good point.
worry about it.
That's why I like the idea of self-driving cars.
Yeah, totally.
I'm more scared of the people in the cars than the robotic cars. Come on.
110%.
Yeah.
And we've got a track record. Look at what we've done over the last couple thousand years. I think the
point.
robots deserve a chance. I really do. Let's not judge them.
I was about to say robots are people too. It's not exactly true, but
Sort of.
they almost are.
Yeah, sort of. So we have a terrific guest today that we are very, very proud and pleased to welcome to the Modern Medicine Podcast. His name is Dr. Pratik Pradhan. He is a wonderful and dedicated ENT physician who practices in the area, formerly from Norwood, or still in Norwood, but soon to be moving into Dedham. So we want to welcome him to the Modern Medicine Podcast. Pratik, how are you doing today, my friend?
I'm doing very well. Thank you, Dennis, for that kind introduction, and thank you for having me.
It's my absolute pleasure. Pratik is one of those terrific physicians who has been a bedrock for my practice and has definitely provided excellent care to probably dozens and dozens of my patients. So I just want to take a second to thank you for the great care you've provided.
Thank you for giving me the opportunity to take care of your wonderful patients.
Let's talk a little bit. I want to talk a little bit about how we met, because I think this is really actually interesting. Do you remember how we met, how we developed a professional relationship?
Didn't Sal Perla introduce us when you had come over to the Norwood hospital from VI originally, and then he
exactly
us?
When I pop shipped to Steward for a couple of years from 2019 to 2021, I left from Beth Israel to Steward, and they had a some kind of mixer or cocktail party for specialists and PCPs to sort of get to know each other. And I think it might have been Sal, introduced us at that. And I took some of your cards and started referring patients to you. And it's how the relationship kind of cultivated. But what I think is interesting about that, Pratik, is that, networks can't force doctors to refer in network. That's against the law. But they can do everything they can to cultivate relationships and make it easy for us to refer to each other. And so I just think about how Steward kind of orchestrated that relationship. And even though, we both ended up going in different directions with our career from Steward, we still kept that relationship going. And it's really benefited both of our practices significantly and our patients over the years.
Yeah, no, I think that's kind of what they call old school medicine. That's how care used to be, is that the primary care doctor knew the physicians and the specialists that they were referring to, either from just, meeting in the hospitals or from medical schools or professional societies or just socially. And now, the whole concept of physician networking is so challenging in the sense that it's really just a checklist off of a computer screen or a network handout, who's in network, who's not in network. Most of us don't go to the hospitals anymore. There's some specialists that are just in hospitals all the time, and we're all time crunched and want to spend time with our families, and between seeing patients and documenting charts and answering phone calls is really so little time to meet. And I would say you're the minority in you're one of the few primary care doctors that I actually, know and talk to, and a lot of, I've seen patients from some primary doctors for so many years, and I couldn't put a face behind them. It's just a commentary on how medicine has evolved, that everyone's in their own little block, and the ability to socialize is so limited.
It is, and it's 100%. I think a great thing when doctors build those relationships, because I really feel like they benefit patients. And I've had this sort of same kind of story play out with multiple specialists that I refer to. And one of the big things I'm trying to do as a PCP is, first of all, get people to the care they need. And there's a lot of things that you do in your office that I just simply can't do in my office. I don't want to send people to Mass Eye and Ear. I don't want to send people to the emergency room. Most emergency rooms, as you know, don't even have an ENT in-house. So we're trying to get people with ear, nose, and throat problems treated quickly, efficiently, without keeping them out of the emergency room. And so our relationship, the professional relationship we've cultivated, has been so wonderful for me to do that. It benefits the patients, yes, and the system.
And I mean, that's, I said, also another commentary on the state of medicine. You think Massachusetts, the greater Boston area, is this great medical mecca, but, and there's so many physicians, but the ability to get appointments, the ease of access for patients is such a barrier. I mean, yes, you have some, neurology appointments are booking out six months to a year. Dermatology, good luck seeing someone for a mole in a year. You could have
Yeah.
a melanoma, and really having access, and that's what our practice really tries to emphasize is access. We try to keep our wait times down for new patients down to 2 weeks if we can. And as a lot of the kind of academic centers, they don't have that flexibility to get patients in the door.
Yeah, and I mean, you do a wonderful job of that, of getting people in the door, and it makes a huge difference. And I'm thinking, in my head right now, of specific patients over the years that I've sent to you, and the ability to get them in has really just made a huge difference. And as you alluded to, it is not uncommon to hear of like a wait time of like 12 months for a specialist appointment now. It's just getting worse and worse. So it's definitely a big issue. I want to talk to you a little bit about your practice, because you're about to go through a big move. You're moving from Norwood to Dedham. Tell us about that. What brought that on, and where are you relocating to?
Yeah. So we're relocating to an office on Elm Street. It's a medical office building right behind the Legacy Center shopping complex, and there's already a BI physician group there. There's an eye specialist group there. There's physical therapists there. So we made the decision to move there. Really, we've been in our Norwood location for prior to when I joined the practice. It must be greater than 40 years, and we have a long history at the Giles Medical Center, which is right across from what was formerly the Norwood Hospital. And then with the closing of the hospital 5 years ago, and not really seeing any foreseeable future opening date, 5 years later, a lot of the physician community has left the area, and it's a real loss for the community. But from a building where even as physicians and patients, we could never get parking. We'd be having to walk a quarter mile to get a parking spot because the building was so full. And now you show up on a weekday, and it's a ghost town. And we've seen a lot of loss of primary cares and specialists from the area. And so kind of what attracted us to that area where you had an office close to the hospital. You can we still see patients in the hospital. You can see doctors at lunch in the cafeteria. That, and just having the benefit of having all those physicians right in the same building, all that has gone away, and the physical plants deteriorated. And so we're excited about our move to Dedham. Hopefully we want to see our same Norwood patients. It's literally just mile or two away from the old office, and kind of being right off the junction of 95 and Route 1. I think it'll be a lot more convenient for a whole new set of patients.
It's a great location, right behind Legacy Place, and there's a PCP office in there, and then there's several others, including my own, that are within a couple miles of there. So I think that will be a great place to get referrals. It is sad what happened to the network of specialists in Norwood. When I started with Stewart, it was really a robust and network of specialists in that area. And I know that, if you grew up in Dedham or Norwood or Westwood, people would kind of like maybe dump on a little bit Norwood Hospital. But I got to say, as much as Stewart catches a lot of crap, and maybe rightfully so for some of the things they did at the end, they actually did a lot to build up Norwood Hospital, make it, I felt like, a very strong community hospital by the time they were really up and rolling, and they built up a tremendous network of specialists. And it's been really sad to see over the last 4 or 5 years, that network of specialists gradually dissipate because of the closure of the hospital.
Yeah, no, it's a tragedy for, the community, and I think they're feeling it and suffering from that loss.
100%. I want to talk to you a little about some clinical stuff in otolaryngology. That's the fancy way of saying ENT. You don't know. The first thing I want to talk to you about, this is something I send a ton of patients to you for, because this is a real, I think, important thing that is still tremendously underdiagnosed, and that is sleep apnea. And I've learned through my years of practice, I like to send, and I've told you this before, I love to send my sleep apnea people to ENT doctors, because I feel like you guys do so much more with the total airway, as opposed to just throwing a CPAP on everyone, which some people do need. But could you talk to us a little about the importance of diagnosing and treating sleep apnea?
Yeah. So, you're correct. Sleep apnea is a very underdiagnosed disease. It's a disease of the upper airway, where when you're sleeping at night, your airway collapses and you're not getting oxygen to vital organs, and so it has an impact on multiple organs, and it's been associated with higher risks of dementia, Parkinson's disease, cardiac disease, stroke, lower life expectancy. The list goes on and on. And it's a very underdiagnosed disease. It's estimated that around 10 to 15% of the population has obstructive sleep apnea to a significant level, and I would say I would say less than 20% of eligible patients are actually diagnosed and treated. So it's just vastly underdiagnosed, and has a significant health impact on people's lives.
So who should be concerned? I mean, if people are listening to this at home, obviously, I would say the vast majority of people with sleep apnea are obese or overweight. I would say that the things I look for when I interview patients, I ask a lot of people, do they snore? I look for people with higher blood pressures, especially blood pressures that might not respond to initial medications. Those are some of the things that I look at and I say, this person really needs a sleep test. I also look for people that tell me they don't sleep well. They wake up a lot, they have insomnia. A lot of times the problem is sleep apnea. Who should be concerned about sleep apnea, Dr. Pradhan?
Yeah, I think you covered the main areas. I mean, I think the most common issue, someone will come in and say, look, my spouse, my bed partner has been complaining that I snore. And snoring is very prevalent, and it's not that all people who snore have sleep apnea, but pretty much everyone who has sleep apnea snores. But snoring is correlated with sleep apnea, and more specifically, snoring with breathing pauses. So a lot of times, a spouse or bed partner will mention that their bed partner is struggling to breathe. Not just a simple snoring, but it's actually like they're stopping breathing, they're struggling to breathe, or they stop breathing altogether. And that's kind of a very telltale sign of sleep apnea that should be worked up. Patients who have chronic fatigue, those are, sleep apnea plays a big role with chronic fatigue. Patients, as you mentioned, who have blood pressure that's not controlled, or cardiac arrhythmias, common cardiac heart problems like atrial fibrillation, are also correlated with sleep apnea, as is obesity. The risk of sleep apnea with obesity is very highly correlated.
And then there are some people that they're not obese, but there's just like, you know this better than I, but there's just like a certain anatomy, right? Like these big muscular people, they may not technically be obese, but sometimes just anatomically, some people can be more predisposed to it, correct?
Yeah, so there's certain body measurements that are correlated with sleep apnea. The one thing that you can see off the bat is the size of someone's neck. So
Neck circumference.
with a very thick neck, like an NFL lineman, has a very high risk for sleep apnea. I mean, it's an anatomic issue with that amount of weight and musculature. When it relaxes, will just collapse the airway. There's no way you can keep an airway open with that much weight, with the loss of muscle tone and lying flat with gravity working against the airway. So that's a common symptom. And then someone who um, uh, not overweight, there are a lot of anatomic factors that we look at when we just do an examination. Yeah, typically, it's kind of the size of their tongue relative to the size of the roof of their mouth. That ratio it impacts whether there's airway collapse. Uh, More so in children, tonsil size is correlated with sleep apnea in children, not so much in adults, but it can play a role in adults. And then um, we do specialized testing where we look at the anatomy behind the throat, the ratio of the tongue to the back of the back wall of the throat, and kind of the whole collapsible tissue above the larynx. So there are a lot of anatomic factors that we that as a primary care doctor you can't see.
Right. And then things like, people have polyps or other things back there, deviated septum, which another thing I'm probably not going to see. And even there was one other I was going to mention, but things, anatomic things like that can also factor. Oh, allergic rhinitis, right? Can severe allergic rhinitis potentially cause upper airway obstruction and lead to sleep apnea?
Yeah, I mean, it's an interesting concept in terms of the role of the nasal airway with sleep apnea, because kind of the nasal airway for most people is the first point of airflow into their lungs. And they've done studies. The initial data was that the nasal airway plays a small role. It's kind of not causative of sleep apnea. It can cause some mild sleep apnea. Mm, there's a lot of literature now that being refocused on that, because I think people feel that it does play a greater role with sleep apnea. It definitely impacts the treatment of sleep apnea. Any of the major treatments for sleep apnea, whether it be CPAP or an oral appliance, those people don't have treated up a nasal airway and they have a deviated septum or severe allergies, nasal polyps. Those patients are not going to tolerate any traditional treatment
Right.
for sleep apnea.
Right.
So,
That's exactly why I send them all to you, because you will look for those things. And some people will just do the test and throw a CPAP at everyone. And I don't think that's always the best care. I want to talk a little about the diagnosis, Pratik, in terms of a lot of the testing now can be done at home. Is that correct? The home sleep testing, it seems to be what most insurance companies will cover now as their first line test.
yeah, and that's a trend in the last 10 years. There are good points to it and bad points to it. Before everyone had to go into a sleep lab, a special place in a hospital or a sleep facility. They'd have to spend the night there and pack up and go to work the next day. There were a very limited amount of beds, so wait times for these studies were very long, and it's kind of really inconvenient for patients.
Oh, yeah.
And nowadays, I would say the vast majority of sleep studies for diagnosis of sleep apnea can be done in the home in adults, which is increases the accessibility. Wait times are, instead of being months or maybe a week, 2 weeks, significantly easier to sleep in your own bed than and have to drive to some facility. And so, and also kind of cost-wise, it's tremendously cost-effective for the insurers in terms of lowering costs. And so there's definitely been a lot of benefits with the home sleep study testing, which is kind of now considered standard of care for sleep apnea.
It's way easier. I mean, the kit gets mailed to the patient does the kit, they either drop it off or they mail it back. They have a result in a few weeks. It's so much more convenient than the old way of going into the sleep lab. And I mean, people don't always sleep well when they go into those places anyways, which is like a huge, confounder, I think, in some ways. So I think it's much better to do the home test.
Yeah, no, it's been a benefit for people.
Let's talk a little bit briefly about the treatment for sleep apnea. Now, when we think of that, the traditional thing, I'm thinking of the movie Hall Pass with the Darth Vader mask, and nobody wants to wear that, especially a younger guy. And some people do need that CPAP, of course. And if you need it, you should 100% do it because you have to for your health. But there are a lot of alternative treatments right now. Could you talk a little about those?
Yeah. So the alternatives to CPAP, which is something we still always recommend to patients, but obviously there's a lot of patients who either can't tolerate it or doesn't fit into their lifestyle. Um, the second option I usually advocate for patients who are appropriate candidates would be something called an oral appliance. An oral appliance is a custom-made device that's kind of molded to the upper and lower teeth, and it has a hinge. So what it does is it brings your lower jaw forward a few millimeters relative to your upper jaw. And what that does is it creates extra few millimeters of space in the airway. And that I've proven to help patients with mild to moderate sleep apnea. And the benefits of that are that patients don't have to be hooked up to a machine. They do have to wear this thing every night, but a lot of patients find that preferable for their lifestyle and traveling a lot. And it's been shown to be very effective for treating sleep apnea. The newer procedures that have come out are based on pacemaker technology. So there's technology called hypoglossal nerve stimulators, which are these devices that are put in the upper neck.
This is the so-called Inspire.
Right. The Inspire is the one FDA approved stimulator in the U.S. market right now. So people just call it the Inspire procedure. Kind of the broader category is hypoglossal nerve stimulator. And so with the current generation of Inspire device, it's actually a mini pacemaker like computer device that's put in through an incision in the neck, and then there is another incision made in the neck, and the there's an electrode or electrical cable that's tunneled up to the nerve that controls the opening and closing of the airway, which is the hypoglossal nerve on one side. And the device can detect when there's an apnea or hypopnea, which is a stoppage of airflow. And if it detects that stoppage of airflow, it sends an electrical signal via the cable to the nerve, and that causes the nerve to fire and stimulate the muscles to open up the airway. So it's really a remarkable technology that's been developed for patients, and it's a great option for patients who have severe sleep apnea, who are CPAP intolerant, because for these severe patients, an oral appliance doesn't work very well, and the health consequences of untreated severe sleep apnea are very severe. So it's really been a game changer for management of these more severe patients.
Some people just refuse to do CPAP. That's it. They absolutely refuse to do it, even though they could. They just don't. They don't like the idea of it. So I think for those people, it gives an alternative. Is it a surgery? You go into general anesthesia?
Yeah, it is a surgery. So it's definitely not for everyone, but for the appropriate candidates, it's a very good procedure. So it does require general anesthesia. The procedure time is on average around 2 hours. It's a day surgery, so you don't have to spend overnight. So you do go home, and there is postoperative care. So after the implant is put in, you have to wait for the everything to heal in before you can activate it, and then around a month after the implant is placed in, then it's activated, and that's when the sleep apnea starts getting treated.
It's very interesting. I want to give the opportunity to my producer here, Dave Yaz, the opportunity to ask some questions, because I want a full confession. He is confessed to being a snorer.
Big time.
Trying to convince him to get a home sleep test. So Dave, what questions do you have for Dr. Pradhan?
Doctor, if is my girlfriend going to leave me because of my snoring? Oh wait, no, sorry, that's better for my therapist. I guess my question is this: I've always been a snorer, but I don't, as far as I know, I don't tend to wake up in the middle of the night. I sleep pretty solid, and I wake up groggy like anybody else. I need my coffee, but if I am a consistent loud snorer, is that a huge red flag? Or I don't expect you to diagnose me over this podcast, but
yeah, I mean, I generally recommend a sleep study for anyone I see in the office who comes in with snoring, with very few exceptions. I think the rate of undiagnosed sleep apnea is pretty high. And people can walk around and they feel that they're functional and not tired, but I see patients with like severe sleep apnea patients who have never complained of being tired, and you're like looking at this sleep study and saying, my gosh, how are you even alive?
So to put a finer point on it, I might not be sleeping. I might think I'm sleeping well
but
Right.
perhaps not, and the quality maybe isn't there.
I think
Is that
we
fair
hear
enough?
that a lot, Dave. from
Is that
a lot of
right?
People, right?
Okay. Is that right, doctor?
Yeah, sleep apnea is an interesting beast in the sense that it doesn't always correlate with patients' symptoms or even what you'll do a detailed exam on someone and you'll send them for a sleep study and I'll say there's no way this lady who came in to see me for snoring who's bone skinny and then who's saying that her husband doesn't want to be in the same room with her, that there's no way that she has sleep apnea, and you come back and she has sleep apnea. There's a lot of issues with loss of muscle tone. So the sleep test is generally the most reliable way to kind of proceed with a treatment plan. Whether for just simple snoring, and I think that's what I tell patients is that there's two different treatment pathways. If whether you're a snorer with sleep apnea or a snorer without sleep apnea, and there's kind of different algorithms and treatments based on that first decision point.
So forgive me if I missed this, but if I do, all right, you've got me persuaded, both of you.
You've
So
heard from
well
two
done.
of us now.
Well done.
You've heard
Yeah.
from two of us now.
Is the home sleep test? Do I need to go to my primary care physician for that, or can I just send away for it, or how's it work?
Yeah, usually, for a medical grade test, which are kind of the reliable ones, you do need a physician's order for them. I mean, they're sort of in like iPhone apps that track your sleep and tell you stuff. I don't. They haven't been validated to a degree of medical certainty. I think that it may be the case that maybe it'll be just you download an app on your Apple phone and Apple Watch, and it tells you how what your sleep apnea index is. But I don't think it's reliable. Yeah.
I'm always scared if I use one of those, it's going to tell me what I say in my sleep, and it's really, really disturbing
Then
things.
you'll need a psychiatrist.
Yes.
Yeah.
It's up to. Yeah.
Two other quick things. I know we're running short of time. I just want to bring up, and then we're going to let you go. Number one is it is allergy season, and I've had a lot of people in my office this year complaining of sort of classic allergic rhinitis symptoms. I think we had a very tough allergy season, high pollen levels this year. When should people seek out medical care for allergies? There's so many over-the-counter treatments. What guidelines could you give to individuals to say, okay, this is to the point where I need to see my doctor?
Yeah, I think a lot of the allergy medications have gone over the counter in the last 10, 15 years where, you needed a prescription for Claritin or Zyrtec or a prescription for Flonase. And now people can pick and choose. And I think if they feel like they're, if they take a Claritin or they take a Zyrtec or they take an over-the-counter nasal spray like Flonase and they feel like their symptoms are under good control, then I don't think they need to see a medical professional. But I think if they're at a point where they've tried, one or two over-the-counter products and still not feeling that they're getting adequate relief, seeing an ENT or allergy doctors is probably the next step for a couple of reasons. They're more potent prescription level medications that work better than the over the counter, and then also in terms of identifying allergies with allergy testing, talking to patients about environmental controls. Maybe they have an issue with a dust mite allergy. So, or they have a pet allergy, or and then also identifying the seasonal variations to their symptoms with allergy testing, and then lastly, we offer allergy immunotherapy or allergy drops if they have really severe allergies.
Yeah, that's really interesting. The other one that I see a lot, and I'm curious what you think of this, is occupational stuff, right? A lot of people that work and they're exposed to, chemicals or scents or dusts, and they think they have seasonal allergies, and maybe there is a seasonal component, but there's a lot of people out there that really have occupational asthma or allergies and really never get it treated and don't do anything about it.
Yeah, that's a tough one, in the sense that it's hard when I see them in the office. You do a lot of occupational evaluations. Like, it's hard to say, well, what's their work environment, and some patients will say that, and I think the allergy testing for mold or dust mites is very helpful in those situations.
100%. And then very quickly, want to ask you about hearing loss. And when should people start to think about getting their hearing tested? And what age do you think that pops onto the radar?
Yeah, so it's interesting, and there's no consensus in terms of screening guidelines um, by healthcare authorities on, like there's, you should get a colonoscopy at a certain age, you should get a mammogram at a certain age. There's no real recommendation on hearing loss. But as hearing specialists, I mean, I think 65, mid 60s is when we typically see patients come in with hearing problems. So in general, uh, it's pretty, it's not a bad idea to get some baseline hearing testing at around 65. But certainly sooner if, you perceive a hearing loss, or, people around you are telling you that you're not hearing them, that's always a good time to get a hearing test.
And noise exposure is a big thing for that too, right? Like even like, a lot of people now wearing headphones and stuff like that. I mean, that's something you have to worry about.
Yeah. So even in, teenagers now with the
buds,
earphone, iPods and headphones that everyone walks around with, we do see hearing loss if they have it tuned up to a point where, if the rule of thumb is if the person next to you can hear your music, it's too loud.
Yeah, there you go. That's a good rule. People should remember that. Okay. I want to thank you so much, Pratik. We're gonna wrap it up. I'm really appreciate this. Was really terrific. Great information for people, and really wishing you the best of luck with the move to Dedham. Looking forward to seeing the new office, checking it out, and no matter where you are, if you're anywhere near us, we're going to keep sending you patients because you've been terrific. So thank you so much.
Hey, Dennis, thank you so much.
Appreciate you. Have a great day, my friend. Going to wrap it up with the clinical case of the week.
The clinical case of the week.
Which is, I think, very much related to Dr. Pradhan's interview, and I just want to bring it up. We didn't talk about this with Dr. Pradhan, but this is a very common presentation in my office. A 50-something-year-old guy that comes in with some swallowing difficulty. And swallowing difficulty, called dysphagia, is a very common symptom. And I would say the vast, vast majority of the time, it is nothing to worry about. It is an extremely common symptom of reflux or heartburn. But unfortunately, it is an alarm symptom, and it does require some further testing. So this patient came in, and there were a couple things that concerned me about this patient. Number one is he had no history of reflux. Number two is his dysphagia developed very quickly over the course of a couple weeks. It was fulminant. Number three is it was associated with a weight loss of 20 pounds over a couple months. And number four was it was affecting his appetite. So I got really nervous about that. And I initially sent him to a gastroenterologist. They evaluated him. They sent him for an endoscopy. The patient, a couple weeks later, the patient came back a few weeks after that and said now they were not only having dysphagia to solids, but liquids in the matter of like 2 weeks, right? So it's fulminant, it's changing fast, and it's worsening. So then I started to get really nervous. So what I did was I referred this patient actually to Dr. Pradhan's office, and Dr. Pradhan didn't see him, another provider over there did. And they were able to, the next day, get this patient in for a laryngoscope. And they were able to see a mass in the esophagus on the scope. They put a scope down there. And sure enough, they admitted him right to the hospital, CT scanned him, and the patient had esophageal cancer. But what I think of when I think of this patient is, if I was still at the Brigham and Women, not to trash them, but wait times are a big issue in that system.
Sure.
And a guy with dysphagia, middle-aged guy with some swallowing difficulty, is like a very common story. So I don't know if anyone would have necessarily raised any alarm bells if they just, unless they really looked at it closely like I did. If that patient waited 9 months, 12 months, 15 months to get an ENT, like some places in our system would ask them to do, they wouldn't have made it that long. First, they would end up in the emergency room at some point in the next few months, but it would have been a huge delay in care.
So, and how many cancer diagnoses do you think are, for lack of a better word, overdue?
You mean in terms of missed?
Or because of delays, like the ones like delays in diagnosis, and sometimes due to the system, sometimes due to patient stubbornness, right?
Yeah, I mean, that's a lot are. I think a lot are. I mean, we have clear screening guidelines for some things like colon cancer, prostate cancer, that kind of stuff, breast cancer. A lot of things there is no screening for. And a lot of times these things present. Look, my job, a lot of it is trying to find a zebra in a field of horses. 1,000 horses walk through my office, right? Wait a minute, there's that one zebra. I never get a warning when the zebra is coming. It's just, I have to be really keen and on the ball to say this could be a zebra. And it's really hard to do that. And I think that a lot of times when patients present in ways that are not entirely clear, it's very easy to miss these diagnoses. But our healthcare system sets us up into that because it takes so long to get in to see specialists. And that is a huge problem right now where, getting a second set of eyes and some testing that frankly, a lot of PCPs can't or won't do, mostly can't do, is oftentimes paramount towards making the definitive diagnosis. And it's all delayed right now.
Kind of a ominous way to conclude the pod, Dennis.
Well, I mean, that's what we do. It is. But this patient has a good enough prognosis, and they'll get great treatment. They have great treatment options, and I'm hopeful and confident that they'll do well. But in this particular case, it was Dr. Pradhan's office that really stepped up and came through and got this person diagnosed and into the right hands and with really minimal delay. And I mean, for someone to come in and first present and within like 2 or 3 weeks, get a definitive diagnosis. I mean, that's
the I guess the moral of the story here. But it sounds like it takes a little bit of luck. And I don't need to tell you, Dennis, that doctors have had a rough go of it over the last couple decades in terms of proliferation of medical malpractice suits and things like that. And to me, this is a good reminder. I'm not just saying this because I produce your show, but it's a hard job looking for those zebras, It
is. Yeah. It is an extremely hard job.
And yet, so you do your job with, I'm sure, pride and expertise, but also it must be a little bit of an anxious day-to-day existence. Your job is to not miss things like that.
It is. Our job is to not miss, and we can't miss once. If we miss one time, that could be devastating. So I can honestly say, I work really hard and tirelessly to try, and I feel like a huge part of what I do is just getting people in the right place. And sometimes, is medical knowledge important? Yeah, it's great to have medical knowledge, but a lot of it is just we care enough to make that phone call, to make that email, to get someone in the right place, because that's a huge part of the battle. And I think that's one thing I like about my practice. We haven't lost that yet. So that's good.
Well, that's a more positive way to end it.
That is more positive. We didn't do the non-medicine topic of the week, but to be honest, I don't know if I really have anything that great. What can we talk about non-medicine? You got anything?
Well, I know you're a huge sports guy.
Red Sox?
Yeah, Red Sox. Yeah. Ugh. But are you continue to be optimistic about the Patriots and what's supposed to be a top-notch draft? And
this is the non-medicine topic of the week. What the hell happened with Stephon Diggs, right?
Yeah.
Wow.
I'd like to say that this is nothing. The video of him supposedly courting some young women with some substance of some sort, and nobody's quite sure what it is. I gotta say, it feels like the beginning of something bad. I hate to say it. Do you agree? Like that he's just going to be trouble? Yeah. I mean, look, I think my antennas are up on it, but I'm not going to overreact to it. Yeah. Yet. Now, if he I don't think this precludes him from being successful in the fall. It shouldn't. Yeah. But, if he comes out and he absolutely sucks and he's not healthy until November, we're all going to look back at this and be like, see, this was the cardinal and the canary in the coal mine. That was the red flag. This is the red flag. Well, I hope not. Yeah. Well, because the Lord knows the Red Sox aren't giving us any joy. And wait a few months, Patriots will be back in camp. God bless the guy. He's living his best life. Apparently I don't support drugs. I've never done drug in my life, and I don't agree with that. But you know what? Who knows what was in that bag, and he's on the boat having fun, and that's between him and his personal people around him. It was just magical pixie dust of some sort. Himalayan salt. Right. Have a great day, everyone. We'll catch you next week. Thanks for listening to this episode of the Modern Medicine Podcast. Be good.